All right, so it's about 7 minutes after 7. You're still watching the AM show. Time now for my banner. We're talking NHIA issues, and I love experiences. So what I would do as we continue to have this conversation is open the lines so you can join in with your experiences, because that's what we want to address. We want to see how we can fix this NHIA issues if we can. Sustaining effective healthcare delivery. We're told that danger is looming as the NHIA nears collapse. Return of cash and carry. Some people even feel that it has come to stay already. So my guest is Archibald Adams. He's the Deputy National Coordinator of Universal Access to Healthcare campaign. And maybe I should start off, or as the conversation progresses, I will bring you that insert of that communications, the public relations person saying that the 2.5 levy is too small. They need a lot more. But let's start this. Archibald Adams, I want to say good morning and thank you for your time.
Good morning.
So we all know the issues that the NHIA is being faced with. They say the money, first of all. The levy that we give them, is it enough from where, because a lot more people are getting on board?
All right, good morning to your viewers. NHIA, NHIS, for us from the campaign, we think that needs more funds.
Okay.
I happen to be part of the stakeholder dialogue that was held by the NHIA somewhere last year in November. And then the CEO complained about the funds, that the 2.5 NHI levy that is being given, or that is being placed on the services and the products that we buy is not enough. He made some analysis, but for us at the campaign, we are not really so much concerned about the 2.5. What we're just saying is that even with a little that comes into, that's supposed to come to the NHIA levy fund, the period at which it's released is the issue. Because for instance, if you know that you are being paid 1,000 Ghana cedi and it comes regularly, it helps you in your planning. But it's the case that your 1,000 Ghana cedi does not even come at the end of the month, comes after 3 months, 4 months, 5 months, and 6 months. What happens is that you're going to be in debt, and as it comes, you pay back these debts, and you are still the same, no improvement. So, I mean, if they are calling for more funds, fine. But what we are also saying is that even with the one that has been approved now, should be released on time, and I mean, easy, so that the NHI can run the system very well.
If you listen to how the process is, what it has to go through, they've said that whether we like it or yes, there has to be this 3 months back pay, kind of, because of the procedures that it has to go through. But whose responsibility is it to give money to run effectively the NHIA?
It's the responsibility of the finance ministry. Let me say the Minister of Finance, because you and I pay the levies wherever we find ourselves, whether we are buying food, whether we are going to the restaurant, or paying for any other service. So once it goes into the consolidated fund, it's the responsibility of the Minister of Finance to ensure that whatever needs to go into the NHI levy fund, it's released on time. I think they do that together with the Ghana Revenue Authority. And I mean, we read, I think last week, somewhere last week, they're talking about automating their systems. So I'm sure things are being done internally, but it's a responsibility of the Ministry of Finance. And then the 3 months allowed period for the transfer to be made to the NHIA levy, it's right. But what we have experienced over the period of time is that it takes more than 5 months. So that's where the issue comes up. And let me explain this to you. Because of the delay, service providers have devised a nice and a dubious way of trying to stay within the system. So instead of charging for a drug of 1 Ghana cedi, they charge 3 cedis, so that by the time it is actually paid, they will not have lost the value of their investment. So that's where the problem comes.
But that's illegal.
That's illegal. That's why I said a dubious way. And I mean, it is all over in the system, and that is what is affecting the system.
As difficult as it may, is this a sustainable scheme that we can continue to run?
Yes and no. Yes, because it is serving the poor. No, because as it stands now, we have more people on, and then their contributions are minimal. Let's not forget that the NHIA is mainly funded by the state contributions, by the premiums the people pay, and then by the investments that is made from the various donor support that the NHIA gets. What is happening now is that people that are supposed to contribute to the NHIA, to the SNIT, have withdrawn. Okay, so what is running the NHIA is just the premium and then the donor support that comes. And that's where the problem
is. That sustainable? And if you say that's the problem, I want us to use the private insurance, for instance. They're solely relying on premiums.
Yeah.
So why are they able to do better?
Their premiums are higher. Their premiums are higher. And unfortunately, NHIA spends so much in collecting the premium, which cannot even sustain its operations.
Yeah, but whose fault is it?
It's a system. It's a system.
Because if it's a social intervention program that government has decided to take, then they have to effectively be able to run it, no matter what.
Exactly.
And I'm just, so what can we learn from the private people? I don't know.
We don't want to call for an increase in premium, because when you do that, then it's going to block the ordinary person from accessing the health insurance. So maybe we'll call for more funds.
More funds from where?
From
because
everybody.
If the little that government is supposed to come forward with, let me not call it the little, but what it has to contribute, if it's not coming on time and you're asking for more, then we're asking for more trouble, essentially.
No, if you're giving birth to a baby and the baby is suffering from stunted growth, it's just the responsibility of the mother to, take a look at the means by which you provide for the needs of the child. So if it's really an intervention put up by government to ensure that the ordinary person, the poor person on the street can have access to healthcare without necessarily paying for it at the point of use, then government must look at it again. Because otherwise, it will just be as if National Health Insurance Scheme exists and it's not really functional.
Amazing. I'm just trying to see, are there real ways that we can revive this and not depend on governments?
We can. If private organizations will want to support, because for companies that have signed on to private insurance, they have taken themselves off the NHIA. So their SNIT contributions their payment that needs to go through their SNIT contributions do not do so. So you have a small number of people contributing through that way, and then a small number of people paying the premiums. As we stand now, from our records, we have just about 38% of the population on the NHIA. What it means is that initially we had more people registering. They have the cards, but they are not active users.
Okay.
They have not renewed it maybe for the second time or third time, or they have not even used it for the past 1.5 years.
So this your record dates back to which year?
2014.
Okay.
And we have cross-checked with the NHIA. We have cross-checked with the NHIA. But in the 2015 budget that was read last year, November, not the reviewed budget, government said they were going to give some support to the NHIA from the charges is going to be placed on the financial services. So there's an opportunity there that we can leverage on. But as you said, we need to look at more innovative way of generating funds. One other thing that the campaign is also pushing for is what we call progressive tax to finance the NHIA. This is what we are asking. Irrespective of whatever we take home as our salary, we tend to pay almost the same. This is what I'm saying. If I'm earning 100 Ghana cedi and I'm paying 2.5% on it, I'm going to pay more than someone who is taking 5,000 cedis, who is paying 2.5. So we are saying that let's tax the rich more and let's tax the poor less. In that way, we'll get more from the rich who can afford to support the poor who cannot afford.
It sounds like a fine idea, but it's not so fine for those who will be paying.
I know.
Because, they are contributing more to a scheme that they are not even on.
No, Mama V, if the scheme is working, everybody will want to jump on board. People are not signing on, or people are not patronizing, because when you go to the health facility, you're not given that care that you think you deserve. So people go to the private health care centers. And let's not forget that it pertains to the major towns. But if you find yourself in a village where the only health facility is about 100 kilometers away, public facility is 100 kilometers away, and you have to make that journey on foot, whether you go there and you get the best as in the standard per the one we are expecting here in Accra, you have to make do with it. So if we all contribute more to it and the system is working, why not?
But realistically,
it's realistic. It is.
Because I don't see how people would be moving from the private where they have all the comforts to NHIS, where sometimes they will tell you, oh, the card doesn't cover this, the card doesn't cover this, when you have another card that covers a whole lot more.
I don't know about the private health insurance.
Okay, so I know a bit more about the private health.
But I'm not sure it covers everything.
No, it doesn't cover everything, but it covers a whole lot more than NHIA.
And I'm sure NHIA would not want to take more onto their plate, because even with a basic one, there are still some challenges. And let's not put all the blame at the doorstep of NHIA. Let's look at the ordinary Ghanaian, the ordinary service provider, a private practitioner who works in a public hospital, uses the name of the patients who have visited the public hospital and then duplicates it as if they had also visited his private health center. And he presents those as claims, and he's been doing that for the past 5 years. He was just arrested last month. So
and that's just one person who's been arrested. You can imagine the number of people who are doing it.
Gradually, we are encouraging the NHIA to do what we call clinical audit, to really send people down to find out whether it is true you've had 72 people visiting the health facility every week or every month, as has been presented. And they are.
But shouldn't this be normal? Shouldn't this be a normal check?
No, it has been. But let's also understand that with an institution like NHIA, it also will be constrained with personnel, because what it means is that aside you receiving the claim at the claims office in Accra or the regional offices, you need someone to go down to verify, and that also takes some time. And that also all must be done within the 3 months that has been agreed upon between Ministry of Finance, NHIA, and then the accredited service providers.
I'm just thinking that if we can, I'm not saying the private insurance companies, health insurance companies are doing a perfect job,
sure,
or they have everything going for them, but I'm just thinking that if we can take our time and learn, a bit from them, because I know that from time to time they also tighten some of the procedures,
sure,
because when you go to the hospital they tell you, oh, now you can't do this, or now you can't do that. If we can take our time to learn, because why are they successful? Now we have a lot more of them in the system. Why do they seem successful? And then, the government run one as usual, I'm sorry to say, because it's government run, then it's not as effective.
I mean, the issue is funds, availability of funds. If the private insurance provider is probably charging, I don't know, maybe 200 Ghana cedi for a premium, I mean, there's funds available for it to turn itself around and ensure that its service providers, the drugs, the equipment, I mean, there's that enabling environment for you to enjoy that quality health care. But unfortunately, at the public aspect or the NHI, that is not available. You have to sit and wait. In the papers last week, the Minister of Finance was saying that 1.6 million Ghana cedi has been released for the 2013 fiscal year. And that was just last week. So you can imagine the constraint that will be put on the NHI to run a system that has funds being released 3 months more than the speculated or the agreed time.
Were we not talking one-time premium?
Yes, we were, but it doesn't look feasible now. I don't know what this government is going to do, but when you look at it, how much are you going to charge him? How much are you going to charge? And you know the issue where people pay and they don't renew. So when the person pays once, does it cover the person till
Thy kingdom come?
Thy kingdom come. And then you know, our system also has a lot of. Let's not forget that Ghana has a young population. So you have more young people below 18, and you have more people above 70 who are all being absorbed without paying for the system, quote and unquote. And then there's also the free maternal health care aspect also. So there are a lot of, let me say, for lack of a proper word, dependents who are depending on the few people who are judiciously paying for the support for the NHIA.
So around this time, asking for more money, I don't think is very possible because we have a lot of challenges.
Yes.
And depending on the priority lists, NHIA may not be getting a lot more money.
We are not necessarily asking for more money. What we're just saying is that government has given birth to NHIA. Let's ensure that it works, because if we fully return to the cash and carry system, it will be bad for us.
And I'm just thinking, the different ways that you've prescribed, these are nice ways, but does it look like we will be able to implement that? I mean, even if government agrees with you and they say, yeah, they will go with your call. It doesn't look possible, does it?
We will. I mean, like you said, I agree. We are, as a nation, we find ourselves in a very tight situation. But what we're just saying is that as we look at other innovative ways of raising funds for the NHI, the one that has been agreed upon, because, I mean, the Minister of Finance cannot tell you and I that nothing comes into the government chest from the NHI levy that has been agreed upon and is being paid directly and indirectly by everyone. So what is due the NHI, let it get to them and on time. So that whilst we look at other ways of raising funds or generating funds from the system or even outside, let's make sure that what is due them gets to them on time, and then they can at least get the wheel running gradually until more funds are put into it and get it running faster.
Do you know if they are able to internally generate any funds at all?
I'm not aware of that. I'm not aware.
Because I know that sometimes organizations can raise funds on their own. You know,
from donors?
From donors.
Probably, but yes, that's also an aspect of funding for the NHI. But I'm wondering how much they can generate because of the various limitations that is placed on government agencies, the processes and all that, and probably sometimes the ties with these funds comes with.
All right, so we'll try and raise the PRO of the NHIA on the phone lines, because this is one area that I also want to touch on. How much of funds are they able to generate on their own? And all, you know, in ways trying to see how we can sustain this NHIS and get it going, let it be better than it is. But may I also say that you're welcome to share your experiences with us. And instead of bashing them, maybe we have different ways that we think it can be better. Your ways are also welcome, so you can join in the conversation on 0302-211-69102, 0302-211-69102. Let's see how we can help. You know, there are people who feel that, oh, I don't use it, so what's my business?
But the issue is that you may not be using it. You find yourself in Accra, Kumasi, or Takoradi, but you have a family member somewhere, you have a friend somewhere who need healthcare at one point in time. The issue is that we are not paying for the worst, but when you retire and you cannot make that so much money and you may not be able to sustain yourself on the private healthcare system and you want to switch onto it, what happens? Because, you know, we've all been complaining about NHIA, but like you're saying, it is for us. Maybe today you find yourself in a good position, but what about tomorrow? What about your uncle? What about your grandma in the village, your cousin, your family member, your church member? Someone who is connected to you will suffer from the system one day.
All right. And I was just thinking that I would also ask this question. Are you ready to pay more in terms of the levy, the 2.5? Are you ready to pay more if you're earning more? Are you ready to pay because you're campaigning for that? Are you ready?
I am.
How much more do you think persons who are earning more should be paying?
I think that should be left with the financial persons. They can, I mean, based on their calculations, tell us that probably we need 1% more or 2% more. But I think that generally as human beings, you want to pay more for something that you know it's working. So if government sets its role as the mother of this institution or the scheme running, and we are asked to pay 1% more, we will pay. I'm sure you will also pay, because then you know the system is working, and you know that when you need healthcare, you can always fall on it. But of course, if it's not working and you don't even see what your 2.5% is being used for, obviously you will not want to pay.
But I'm trying to personalize it, and I'm trying to ask myself the question.
Nobody wants to pay more.
You're not
tax.
using it.
You're
not using it.
Yeah.
Are you ready to pay more even though you're not using it? It may be benefiting people that you have no idea are benefiting from.
Yeah.
But are you ready to pay more? Because times are hard, man.
I know.
Times are really hard.
I know. But that, like I'm saying, if it's working, I mean, let's assume NHIA is running very well, and you are paying, now what is happening is that then for you, for instance, you are paying double, because you are paying for NHIA, which you're not using, and you're paying for the private insurance. So if it's working, unfortunately, maybe you will have to switch from the private to the NHIA, which you're already paying. Because don't forget that, I mean, in one way or the other, you're even paying more than once for the NHIA. You're paying through your SNIT, you're paying through the 2.5%, and then other ways also that NHIA will deduct some tax from you. So if it's working, why not?
Okay. So the phone lines.
I have an NHIS card.
Okay. I'll come to whether or not you use it.
I use it.
030221169102. 030221169102. Give us a call and share in your experiences and answer the question as well. Are you ready to pay more? Let's speak to Mahama. He's joining us from Wale. Good morning, Mahama.
Good morning, Mama V.
Are you related to the president?
Well, not really.
Okay, so let's hear what you have to say.
I'm actually happy with the issue you're discussing this morning, because the National Health Insurance scheme was a very good policy, I would say, that was introduced to kind of ensure that the health care of Ghanaians, of course, are given some kind of seriousness, and let me say, to understand that even the poor ordinary Ghanaians can get better health care. But the issue in Ghana is that it's like we can't introduce a policy without attaching some kind of political interference into it. And that, to me, always affects whatever we try to bring on board to help the Ghanaian people. Because we look at how, like the gentleman in the station is talking about, there's a percentage of the taxpayers' money always deducted to ensure that healthcare or the health insurance scheme is able to function. Now, the big question is that where does this money go to? We're told that a separate account was created, and now it has been boxed into one single account. Now, it is a sub account. That means that everyone goes in there and top. So, when it is necessary for health insurance to get reimbursement to ensure that they are able to refund, or let me say, restore the health centers to go on with their activity, there's no money in there because those monies are directed or given other attention. So what I'm saying is that the policies are good. Ghana, we have good policies. But can we decouple politics out of it?
Okay.
I am calling from Wale, and as I talk to you,
so,
if you go to the Wale hospital, you have to buy hand gloves. You have to buy paracetamol. If they are going to give you drips and other things, you have to buy everything. There is nothing in the hospital. The doctor and the medical staff over there are complaining and complaining.
So let's take this hospital you're talking about. What is the political interference here? Because I want to appreciate that better.
Yes, if the hospital, I'm not talking about the political interference in the hospital. I'm referring to the scheme, the health insurance authority. If you look at the way it is being run, it is like there's so much, because the executive takes charge or responsibility of it. to me, that is the issue we have there.
Okay.
Because, yes.
All right.
What can we do to ensure that, like there's that kind of separation? It's not alone and doesn't depend so much on the executive.
Okay. I get you, Muhammad. Thank you very much for your contributions. Very useful things you've said. Let me move on to Ike, who is somewhere in the Western region. Ike, good morning. Thanks for holding.
Good morning, madam.
Yes, sir. Let's hear you.
Yeah, the government wants us to pay more because the current premium is inadequate. But I don't think it's fair to ask the subscribers or the users. Just last Sunday, I went to hospital, which I will not mention the name. The drugs they gave me, they were 3 packs. The 2 of them that is a bit expensive. It told me that the health insurance doesn't cover. They make me pay, which is 15 Ghana. The most annoying thing is that the drug that they gave to me is just 2 weeks to expire. Just 2 weeks to expire. And I don't understand. And with this, you said you should pay more. If I have health insurance and it's just 15 Ghana, this can cover, and you're asking me to pay more, what are you trying to tell me? So I don't understand. I think the government needs to come out more and explain things to us to understand before maybe we can hold on to what we try to propose to us.
Okay.
So that's my contribution.
All right. Thank you very much, Ike. Let me talk to Jonathan, who's joining us from Bongo. Hello, Jonathan.
Hello. Good morning.
Good. Good morning. Thank you for calling.
Bongo as we usually do. We greet Bim Bim and you respond now. I think the picture of Bongo are listening. So I say Bim Bim.
Naba.
Thank you very much.
Thank you very much. Too. Let's hear you.
Yes. I think this morning you are discussing an important issue that at least all of us have to contribute about the health insurance. And I will begin from where Muhammad ended. The health insurance, I would suggest if we take it from government or the administration of government, for instance, because it's like there's much politicization in it. If my memory can serve me right, there was a time you brought Mr. Sylvester, the CEO of Health Insurance, into your service. When people even phoned in and said the scheme was even dying, it was collapsing in some of the districts, he was agreeing. He was saying that no, it is effective. And I can bet you, Bongo Hospital, if you go there right now with your card, they'll give you, if they realize that you are coming there with a card, there are some medicines that they'll write for you that you should go and buy. Meanwhile, if you go there and inspect thoroughly, you get them in the hospital. So what I would suggest is that if the king can be an authority of his own, where a subsequent government that will come will not appoint the CEOs, I think it will help. Thank you very much.
Okay, thank you very much. I see where you're coming from. Let me speak to Raymond and I'll come back to you, Archibald. Raymond is joining us from Agoti Mekpetoi. Hello, Raymond.
Hello, madam.
Yes, sir. Good morning and thank you for calling. Let's hear you.
Good morning, madam. Yeah, my message is simple. Not long ago, we heard this NHIA government saying that they are going to introduce one payment premium. Meanwhile, they knew very well that what they are paying 2.5% cannot sustain the school. Meanwhile, they made notice how to come back to power. Now they got power. They are not saying what they are getting from our money is insufficient. We don't want them to get anything more than that, because we are not benefiting from what the National Health Insurance is about.
Okay.
Thank you very much.
All right. Thank you, Raymond. I'm sure they got your message. Let me speak to Francis. Hello. Okay, I think I lost you there.
Good morning.
Oh, good morning. I still have you.
Yes.
Okay.
In fact, the health insurance has been so helpful to the people of Ghana.
Hello, Francis.
I have a problem with the yes, please.
You have a problem with?
Yes, the way they started the whole system. Because, any social intervention, sustainability is always a problem. I don't know anywhere on this earth where people just contribute minute towards their health care. A whole year, somebody will just contribute nothing. It was even just only 18.
Okay, so if I get what you're, so you think we should be paying more?
Yes.
Okay, but are you ready to pay more? How much more are you ready to pay?
Why not?
Okay.
Yeah.
All right.
50 cities a year. Yeah. And another thing, you see, the whole health insurance is politicized. You could imagine NDC government will pay this one-time premium. Where are you getting the money from?
Okay.
Now, all our hospitals are collapsed. They don't have drugs. Poor quality of services because you go, they'll tell you no drugs, no medicine, just because health insurance is not paid.
All right. I get your point.
The kind of services we need.
Okay.
Yeah.
Thank you very much. And I'll speak to Francis and pause with the phone calls. I have to come back to the studio. So, Francis, I appreciate your call. Thank you. Let's hear you. Hello, Francis?
Hello.
Yes, Francis, we can hear you. Please speak up for me.
Yeah, my contribution is that for the premium that paid, not that contributed, see the 2.5. But those that are working and not need contribution, they are paying equivalent to what that is.
Hello, Francis?
Hello?
Francis, can you reposition yourself because your line keeps breaking? Hello?
Hello?
Let's see if it's better.
Okay, my issue is the 2.5%.
Hello, Francis? The levy. You're talking about the levy, the 2.5. You're saying not...
Yeah. Yes. Yeah. Those who are working and contributing to me, they pay that. But the problem of those who are not contributing, who supposed to pay an amount equivalent to what they should also pay as their levy. How sure are we that they are also paying that? Because sometimes we end up paying the money that they make with the package of the health insurance, those health insurance officials.
Okay, I get your point. Yeah, I get it. I'll try and put it together. Thank you very much. But it's a very important point that you make, Archibald. Let's start with the last person saying that, because if we say we're increasing the levy, it's still the formal people who pay through the formal means who will be contributing to this. How about those who are not formal workers, if you like?
I think that's another area that we as a nation have not looked at. Because, I mean, let's look at even the people, the market women, the businessmen who are not in the properly structured way. I mean, do they even pay their SNET? How do we get to them to also contribute to the scheme? And they will probably hit about 40% of the population. So maybe that's another way we should look at in raising more funds for the NHIA. But I like the comment that was made by the Raymond, the fact that we should be able to pay more for healthcare. And that's something everybody is trying to fight. Currently, the premium is just about 12 cedis.
For the whole year?
Yeah.
Wow. Let me just engage Salom for a while, and then I'll come back to you, Archibald. Salom Adonu is communications manager for the NHIA. He joins in the conversation. Salom, good morning. Thank you, for agreeing to speak to us.
Hi, Mamavi. Good morning, and thanks so much for having me.
I don't know how much you've been following this conversation, but we're looking at how we can sustain the scheme. And we've gotten very interesting views from people who also phoned in to join in the conversation. But I want to ask, first of all, how much do you internally generate? That is to say, the NHIA, what kind of donations do you get and how much does it come up to?
Well, thank you very much. The NHIA is a pro-poor policy. It is a non-profit organization, as it were. We don't generate money, but we spend a lot of money, which means that a lot of the money we spend, comes from tax, specifically comes from 2.5%. also get some money from NIC, which is part of the sources of funding of our activity. We also have some money from premiums we collect. And premiums we collect potentially should be our greatest source of generating funds internally. But you see, because it's a pro policy, and by law, the law which established the NHIA, the Act 852, you know, we are a bit constrained in pushing ahead with premium collection. I say so because the Act or the law makes 70% of our people non-paying members of the scheme, which means they don't pay premium. About 70% of them do not pay premium. And by 70%, the breakdown is as follows. We have all persons under 18 years enjoying the service for free. We have all pregnant women enjoying the service for free. We have all aged people, who 70 years and above, enjoying the service for free. People in leprosteria, people in special homes, mental health patients, and a lot of people, you know, enjoying the service for free. So if you look at people who actually pay premium, you're talking about just 30% of our subscriber base who pay premium. And mind you, the premium we collect has not increased since the scheme was established 10 years ago or 11 years ago. And that is because a lot of things in this country have moved forward. I mean, electricity tariffs are up, water bills are up, you know, we have exchange rates and everything going up. You know, medical inflation is high and a lot of other things. So we have come to a place where we are saying that our expenditure now outstrips our income. And rightly so, because, I mean, there is a 2005 ILO, the National Labour Organization report that I referred to in this case. The report said that, I mean, that was even before the scheme really got operational. But as a prognosis, the report said that the scheme will come to this stage after about 9-10 years. And we've been able to move, and we are in the 11th year, approaching the 12th year. You know, so what is important at this stage is extra sources of funds or an increase in the total amount of money to receive from the state or from the taxpayer, you know, in order to be able to do more things. Okay. And a lot of the things have remained the same. But the economy is expanding, which means that the 2.5% we get, you know, as a percentage of GDP and all, will have to increase. But our operations and our membership and everything we do has outgrown this growth in the economy. So we need extra sources of funding.
Okay, so Salom.
In 2000, if I could just give you this now, in 2005, our entire membership base was around 1.3 million. As at December last year, 2014, our membership base expanded to 10.2 million. In 2005, we paid a claims of about 7 million. In 2014, our total claims burden goes to 940 million cedis. In 2005, total utilization was, it was just a little above 3 million or so. As at last year, 2014, utilization has risen to 33 million. All these key performance indicators have increased, which means that the NHIA is working hard, is doing a lot, is trying to cover a lot of ground, but we are incapacitated because our sources of funding are unable to support the kind of work we do. So what happens is that every year, the money is released for that particular year. We end up using that particular year's money to settle our arrears for the previous year. So getting to the end of the year, that gap remains. So when the following year's money is released, you know, the ensuing year, we use part of that money to also settle the arrears for the year before.
Okay.
Like we have now, so, you know, we have a couple of months to pay, about 4 or 5 months to pay for last year. When money starts, you know, getting released for 2015, we first have to use part of that money to settle the arrears for last year. So it's a situation of robbing Peter to pay for every time, and we are saying that.
So Salam, hang on for me for a while. So we know that the way that we're going is not sustainable. So how do we fix it? Is it possible? Because my guest in here, who is the Deputy National Coordinator of Universal Access to Healthcare Campaign, is proposing a few things. One of the things is those who are contributing the 2.5. Can we look at those who are earning more so they can contribute more? Is this something, you know, that you've thought about, for instance? And those who are not contributing the 2.5% at all, but who are still working, how can we get that 2.5 from them? And then again, I'm also asking, is it possible at all, seeing that from the way we're going, it's not going to be sustainable? Can you also generate something on your own as NHIA? There must be ways around this, Salom.
Yeah, of course. I mean, all the things you have spoken about are things we have said ourselves. I've said in proposals, you know, to our ministry, and I believe they're looking at it. In October last year, we had a stakeholder engagement on the benefit package. The benefit package is the basket of conditions that any health insurance provides. So if, for example, you present a condition outside of the benefit package, I mean, you will not be covered. And in Ghana, we have a very generous benefit package, which covers about 95% of all reported cases. And even on this front, the World Bank even says that our benefit package is just too generous, you know. So it's something we are working on. Talking about the 2.5% and all, I mean, you see, what I always say is that the NHIS will work perfectly or will work to the level we expect it to work if other actors of the state, you know, are also operating at optimum level.
So other actors, i.e.?
Yeah, I'm just coming in. It is not part of NHI's mandate to go fishing out for people to be members of SNIC, for example. So, for example, if an organization somewhere is not paying SNIC for its workers, it is way beyond NHIS or out of NHIS purview to go get people to pay SNIC. That is not our job. Our job is to manage the NHIS, and that we are doing. For example, if we have poor data management system, you know, in a country, for example, it is not NHIS's job to fix that. I say so because elsewhere you have data on everybody, and you know exactly how much everybody earns. So the premiums we collect, for example, typically should be graduated, so that maybe what you pay as premium should not be the same thing that maybe a KIA should pay, because you obviously will be earning more than the KIA. But as it stands now, when you live within a certain geographical area, irrespective of your earnings, you pay the same thing. That is the best we can do, because we simply do not have the system as a country to track how much each person earns, and if that affects how much tax is collected on a national scale. So I think these are bigger issues, bigger than the National Health Insurance, which we believe that other agencies are dealing with. But maybe because the scheme is going faster, the deficiencies in these other systems are rather coming up, you know, faster. That is where we are. Talking about equity, I made allusions to the fact that what you pay, for example, should not be the same as what the car somewhere should pay. That is an issue of equity. Another point in the equity bit is that, as we speak, probably if your son or daughter is under 18 years, no matter how much, no matter how rich or poor you are, that son or daughter of yours would not have to pay premium simply because the person is under 18 years, and that's by law. And we are saying that that provision of the law, you know, as we speak now, is not helping the scheme, because you cannot make an under 18-year-old pay premium, no matter how rich that under 18-year-old is. And if you look at the demographics of our country, under 18-year-old constitutes a huge chunk of that, and that huge chunk do not pay premium. We are proposing that the premium payment, which is our major source of funds generated internally, should be on need basis. That provision should apply to people who cannot pay. So if you demonstrate that you cannot pay, then that provision applies to you. But if you can pay, then how much is the premium? I mean, the whole year, you pay sometimes less than 20 cedis, you know, for your health care throughout the year.
But
no matter how many times you get sick.
Salom, is that an issue? Are we still talking one-time premium?
No, that is one-time premium. This is yearly premium.
Yeah, I get it. Yeah, so I'm asking, is that an issue in terms of the yearly premium? Is it too low?
It is an issue. It is an issue. I mean, the equity base is an issue because, you know, if the premiums are graduated, then the essence of a social health insurance is realized. As we speak now, everybody pays the same, which is not equitable. If I'm a millionaire today, I only pay 20 cedis or so for my health care for the whole year, no matter the number of times I fall sick. If I poor somebody somewhere in Accra, I mean, he doesn't even have a sustainable means of survival, is to join the NHIA. That person also pays 20 cedis or something. That is really not fair on that person. And it's not fair on the
All right, Salam. Obviously, there's a lot more work that we have to do. But I appreciate it if you can make time and be here. Then we can have a longer conversation. But for now, we have to leave it here.
Exactly so.
Yes, thank you. Thank you very much. You just have to wake up a little earlier, and then we can have a longer conversation. Salam Adonu, the communications manager for the NHIA. Archibald is here with me. Archibald, there's also the political aspect that we haven't tackled because a lot of people hit on it. You are, from where you are, you see clearer, so you can comment on this.
Yeah, I think as a nation we must move to that state where essential services like health and education are separated from politics. I mean, like the caller said, Raymond or one of them said, I mean, there's the invisible hand of government moving all over around our educational sector, our health sector, and then the things that matters to our well-being. Because, like he said, why should a hospital not have gloves? And I'm being told at Ashaman for pregnant women who need to deliver, you have to come with your own fan, you have to come with your own water.
With your own what?
Fan, because the place gets hot. And then you have to come with your own water. And then some other things that are listed for you when you're about to deliver.
Oh, because you're coming with NHIS.
Exactly. And then these things are not provided or are not being made available for the beneficiaries of the NHIS. So I want to agree that something as critical as our healthcare should not be politicized.
But how is the politics showing? Is it because it's the appointment of the top executive is coming, from the presidency? I mean, how is it reflecting in that?
I think it has to do with the appointment and then the processes as to who is running what and who is doing what at what point in time. If we have technocrats running the system, I'm very sure that, I'm not saying that those in position are not technocrats, but they have some alliance or they have some homage to pay to whoever appointed them. But if you know that you've been appointed for a particular period of time to fix a problem, you fix it irrespective of who is in power and who is giving the funds or who is doing what or not. That aside, I think also that we as Ghanaians must also begin to speak and take some of these issues as ourselves. Unfortunately, we have allowed our politicians who come in only for 4 years or more to determine how these things that are essential to our well-being to decide on these issues. I mean, there are so many issues about the health system that have been left unspoken or untouched. Because once you touch them, you are being tagged as a politician.
So who do you speak to? Because you're campaigning for a lot of things. You have great ideas,
yes.
But who is hearing you? Who is listening to you?
We've been talking with the NHIA, and we've also met with the Parliamentary Select Committee on Health to also make these proposals known to them, so that as and when there are opportunities for them to make statements on the floor of Parliament, they can make this input. And we are trusting and believing that one day these issues will be accepted. Because for us at the campaign, we know that the NHIA is working, because people outside Accra, people outside the major towns are benefiting, irrespective of the challenges, and we can make it better.
Yeah. All right. I'd like to say thank you, really. I like the ideas that you brought on board.
Welcome.
And I appreciate the fact that you also called in and then contributed. I like the diverse ways that we're thinking about the issues that are bothering us, the everyday issues. And this is one really important subject, health. So Archibald Adams, Deputy National Coordinator of the Universal Access to Healthcare campaign. He's been my guest here. We also spoke to Salam Adonu, the Communications Manager of the NHIA. And I have to make way really for Roland Walker. He's got the AM Talk. Stay with us. You're still watching the AM show.